Hello, everybody, and thank you for joining the webinar today, Telehealth 101 Tips for Successful Rollout. I want to go over a few housekeeping items. First, this webinar will be recorded, and we will provide the recording available within 2 to 3 days after the webinar. We're going to talk a little bit today about the market growth and the rise of video telehealth, what's driving the growth, really talk about the patient demand coming from rural areas and different demographics, as well as talk about both the revenue and operational use cases for video telehealth, things that you might not have thought about. Really talk about prioritization around some practice areas that make the most sense, and then really dive into some billable codes that are current and available today, as well as what's coming with the new legislative timeline. Talk about some tips for getting started and some successes, and then really talk about different types of video telehealth platforms and considerations for video telehealth providers. So first, I want to talk about the market growth. We've seen a huge rise in video telehealth over the last few years, going from over 350,000 patients just 5 years ago to over 7 million so far in 2018. Over 2/3 of Americans are willing to see a doctor online. A lot of that is driving from the comfort level and it being more available than it was, in addition to patients are consumers. And so the need for convenience and really the busy lifestyles we lead and being able to pretty much buy anything with one click at this point has really driven that. Over 50% of hospitals are using some form of telemedicine. That may not be the ability to provide patients telemedicine from home, but could be connecting hospitals and doctors, but they're using some form. And that increase we've seen is almost a 2,000% increase over the last few years. So talking a little bit about convenience before and patient experience is really driving some of that growth from that perspective, and also patient satisfaction. So 85% of patients surveyed that have done video telehealth were satisfied with their video telehealth versus 64% of an in-person visit. A lot of that has to do with wait time, over 2 hours of wait time for a 10-minute visit. And so really from a patient satisfaction standpoint, it's significantly higher. And patients are really preferring video visits, and that's really across all demographics. But really from that perspective, especially in pediatric care, 74% of patients with children prefer telehealth. That goes back to loading up the kids and having to go to appointments and going to ER and clinics and so forth. And then another couple key areas is really primary care, preventative management, and then even elderly care. And a lot of that has to do with, just not wanting to get out of the home and having a provider, a younger patient that's or family member that's taking care of them. So more demand is coming. 50 million consumers say that they would switch one provider over another for those that did have video telehealth. And that's purely from a convenience factor and the ability to, be able to attend appointments and follow up and surgical and things like that. As millennials become more and more patients, as well as Gen Zs, those numbers will continue to go up. 22% of millennials do not have a primary care physician. So, it's really about that convenience factor. It's about having to schedule that appointment, and really with there being, clinics and, the emergency rooms and being able to walk into any place and see a doctor, that's really reduced the care of, wanting to make an appointment and being able to do it on a millennial schedule. 60% of millennials want telehealth to eliminate an in-person visit, and 71% really want their doctors to have a mobile app to book appointments, to be able to share health data, and really manage their preventative care. Want to talk a little bit about the primary care kind of desert that we live in. 65 million Americans live in a primary care desert. 1/3 of states really have acute care needs, and it's averaging 24 days to get an appointment in top 15 metropolitan areas. So that's really driven a lot of the telehealth, as well as some operational and revenue use cases for telehealth. So want to talk about some use cases that you may or may have not thought about, and then talk about some particular practice areas. So specialized medicine, you've seen that in telehealth for a while, where from the originating site, especially in rural areas, the ability to video in specialty, especially when you're talking about neurology and stroke victims and things of that nature. So that's been there for a while. You're seeing more and more of hospitals going to no waiting rooms and being able to video in other doctors and having kind of one internist, and this is a great area. Seeing a lot in the hospital areas, really taking kind of that ER, especially trying to compete with minute clinics and those popping up, and folks not wanting to go in the ER anymore. So being able to virtualize that and really make that video telehealth also, is all the doctors that are part of the hospital networks, really helping them kind of grow their practice areas and have some operational efficiencies there. Follow-up care. So, being able to have more proactive preventative care, especially when you're talking, diabetes, kidneys, cancer, things of that nature, especially when you really know the patient, and instead of reducing that patient travel time, 2 hours round trip for a 15-minute appointment, really increasing the engagement there. And insurance companies are really starting to back that preventative care. Pre and post surgery. So having those pre-consultations before the surgery, and then post follow-up when the person doesn't actually need to be in front of you. Given the quality of the cameras, given the quality of being able to see things like skin infections and wounds and things of that nature, that's really helped with being able to do video. After hours, so especially when you're talking about pediatrics and OBGYN and things where there's a lot of after hours calls, the ability to support your existing patients, doing that and being able to bill both from insurance, commercial, and private from that standpoint. Those are really some areas. So when we look at prioritizing practice areas and what makes sense, so a lot of hospitals really kind of looking towards what areas do they start with, what makes the most sense, what should they prioritize. It's really not trying to tackle every area right out of the gate. I know everybody is in a little bit of a hurry with a lot of the billable codes that are coming in January, and trying to get a solution in place, and then trying to prioritize practice areas. And so want to talk a little bit about some of those practice areas and what makes sense depending upon the areas that apply to you. So number one, on the mental health side, really crisis mental health. When we're talking about, mental issues, maybe you're a rural hospital, maybe you're a practice group and need to have that. Suicide, the ability to follow up and really engage. Not everybody anymore can come into an office or a facility on a weekly basis. And so really keeping that engagement, keeping that patient proactive care there. Addiction and substance abuse. So we talk a lot about that. We recently did a pretty lengthy podcast on the opioid crisis, and how really to fight that with video telehealth and peer-to-peer counseling. So not only on the video support, on being able even putting your admissions folks and counselors on addiction and abuse, but post-rehab, that peer-to-peer and that counseling support, especially with insurance companies and Medicaid having to pay with the opioid crisis and other addictions, having to pay 2, 3, 4 times for folks to go to rehab. This is a great way to really reduce that and get the patients better. OBGYN and pediatrics. So really the after hours, the follow-up appointments, a lot of things around new mothers, even with breastfeeding and peer-to-peer from that standpoint, even with, cancer patients with kids and support groups, as well as being able to connect to doctors in rural communities. Something you might not have thought about is really around medical device support. So as dialysis and things like that go to home health and chronic care management, especially post surgeries when devices have to go home. There's a lot of, kind of calls back and forth and support that's needed and questions, and being able to see what somebody sees in home. It's one thing to, show somebody a device and then send them home and they're in their environment and it's not working properly. And a lot of times that leads to go back to emergency room visits. So being able to support that and see video-wise what they're seeing and be able to help that is an operational efficiency. Telehealth has been used for a while for stroke, especially in rural areas, to be able to connect to specialists, and that will continue. Especially if you're, in neurology and, you're in a bigger city, being able to support more of these rural areas. We talked about non-emergency and clinical from that standpoint, and the other one is really around chronic care. So especially when you're talking about internal medicine doctors and you're talking about nephrologists, you're talking about diabetes management, things of that nature, really having that, talking about nutrition, talking about, supplements, being able to manage that care remotely. And you'll have some of those billable codes, additional billable codes coming in January. Over 30% of dialysis patients are now doing dialysis at home, given kind of the guidelines there on the wound care, preventative, the checkups that are required, and so forth. Being able to do that via video, being able to, obviously, dialysis patients ends up in the hospital a lot. And so anything preventative that can prevent that, you'll see some new billable codes on that. So I want to talk a little bit about billable codes. We get a lot of questions. I know it's super confusing. It's very tricky from a reimbursement perspective. And so it's really broken down into a few categories I want to talk about today. So commercial insurance, private insurance, whatever you want to call it. There's a lot of the large insurance companies have really seen a lot of benefit in it. They're starting to more and more reimburse for it and cover it. You have Blue Cross Blue Shield, Aetna, Cigna, United, all that are now promoting telehealth, paying for telehealth. It is policy dependent. So it really depends on the patient's policy of what's covered. But it is using the billable codes. It's using an identifier, and 38 states are covering telehealth reimbursement. And so it does require the 95 modifier, but there's really some good resources for the insurance companies of what you can bill for, starting at, kind of 15-minute increments and going up. In addition to that, a lot of practices, a lot of hospitals are charging a convenience fee, which is, very similar to some of the docs on demands and things like that you're seeing that doesn't use insurance. That's just straight up, pay on your credit card for a visit. And so that can be done, and that sits outside of the insurance. A lot of people, patients don't mind You'll see by some states they're, $95 for, just a couple minute consult, and people are willing to pay that versus having to go into the ER. A lot of times that's already cheaper than their copay anyway, or any type of deductibles. So you have options from that standpoint. And then on the Medicaid side, Medicaid bill is very similar to the how insurance does. They do use the GT modifier. There's 49 states that Medicare is currently covering from that standpoint. It still requires on some of them originating site. However, there's 10 states, we have them listed here, that allow home to be originating site. And a lot of that's going to change in January, which is why everybody's kind of at a scramble, as being able to have a telehealth platform that allows patients to be at home, not providing it on a cart you might have in your facility today. Now, where it gets a little hairy and is the most complex is really on the Medicare side. So Medicare is definitely the most complex. The codes really haven't changed since 1995. There's, a lot of legislature trying to change that, and a lot that's kind of going through. It does require that there is a healthcare provider at a distant site. It does require the patient to be at an originating site, and that originating site, we have some listed, and you'll see some links in the appendix here. But some of the originating sites can be doctors' offices or practitioners' offices, hospitals, any healthcare center that's, a federal healthcare center, a renal dialysis center, skilled nursing, and community health are kind of some of the big ones. Those allow for, there's really kind of 7 categories there. You can get reimbursed for the telemedicine rate, and there's also the ability to have a site facility fee. So there's a couple of different criteria for that. There's some really good links and resources that you can get that information from a Medicare standpoint and kind of see what codes apply to your circumstances. And so really, you've probably heard a lot of buzz about, from a legislator standpoint, of really what's coming in January. A lot has been passed at the state level. For an example, we're out of Texas, and Texas had 0 votes against it, and so it'll be coming some sooner than from a federal perspective. But it's fully expected that January 1, these categories will be in effect at the federal level. And so I want to talk about a few of those. Obviously, dialysis is a big one, given the rise of home dialysis and the care of the dialysis patients, that the monthly visits at home will be able to be done via video telehealth. So that's one of the categories that's up to be passed to be effective January 1. Patient assessments, really that's checking in, assessment of a patient. That could be pre, post-surgery. It could be any type of check-in that's going to lead to an in-office visit. So we'll expect more from that standpoint. Stroke services, again, that's some that, given some different sizes of populations and distance to hospitals and things like that, that can be done in certain areas. A big category is substance abuse. That will remove the originating site, especially for Medicare and Medicaid. So that's really where you'll see a lot of that counseling, a lot of the support, things like that. The insurance companies and Medicare, Medicaid are really getting behind trying to prevent the multiple admissions to rehab facilities and addiction facilities. Back over here, provider to provider. This is really going to allow, doctors to talk to each other and PAs, and really, for specialty consults, especially for rural areas, for bringing in and videoing in other, and getting opinions for specialty areas and things of that. So that'll definitely be great from that standpoint. Mental health. So Again, very similar to kind of the substance abuse, mental health, really on remote video and being able to have those appointments from that standpoint. And then the more site availability, this is really around hospitals, rural areas, counties, less than 25,000 people, lifting some of those guidelines and providing some additional support from that perspective. So really want to talk about some tips on getting started. We get a lot of questions on, hey, we're new to video telehealth. We don't know where to get started. How do we be successful? You may have a video telehealth platform today. You may be looking for one. And so want to really run through some of those, and some may apply to you, some may not, but really starting with today's potential. So whether you're a hospital, a mental health, substance abuse, whatever it may be, looking at the types of patients you have today, the types of services you have today, seeing what you can bill for today, and going back to those categories that we talked about. So going back to what you can bill today from a commercial insurance perspective, Medicare, Medicaid, or what your patients would be willing to pay for, if it's a convenience fee or complete private pay. And then aligning that to really putting on your patient's hat. I mean, you probably have a good sense of, patient complaints today, what patients like, what they don't. And sometimes you may not know. And so talking to patients about it, or going off the industry stats of really, what patients are all about, which is convenience. And so, looking at really kind of putting together, we have a really nice matrix that we kind of use from a prioritization standpoint, but really, what are your objectives? Or do you have operational objectives? Do you have revenue objectives? Do you have objectives to get new patients? Do you have objectives to lower kind of your retention rates? Are you losing patients? And really kind of putting together that matrix of kind of how it aligns. That'll really help you kind of prioritize, where to start. And then also aligning that to, you're going to have pushback from doctors. You're going to have pushback from PAs or staff, just because, everybody has their day job. Everybody has new technology. But this is, it's not the future. It's today. You have to do it to stay relevant. You have to do it to stay current and keep your patients. So starting with some champions, getting some feedback. It's an evolution. Your process will change and get better. And then looking at, which providers, if you don't have a technology provider today, which provider is going to meet that number 3, that matrix, and really kind of aligning to that. Then looking at from the technology perspective, and we're going to talk about 5 a little bit more in depth, but picking that provider and really what goes into that criteria, but then getting the technology implemented and training your staff and doing that in the easiest possible way, doing that most efficiently. People think, oh, we've got to have this in place for January 1. Well, no, you're kind of behind the 8 ball, because you want to get it in place. You want to get your folks trained. You want to start getting those operational efficiencies now, working with what you have. So come January 1, you're, full running perspective versus trying to, wait till January to get it implemented. I mean, some vendors take 9 months to implement. Some vendors take, days or weeks. So it just depends on what you're trying to do and if you're trying to do anything with EMRs. And then start with the end in mind. Really come up with your goals, come up with the tracking. How are you going to measure it? And really, around the ROI. So when you're looking at the technology providers, you're looking at the total cost of ownership. What's really going to be the ROI? How many appointments will you need to have? Or what's, how much operational cost will it take out? And really backing into that, and then looking at how you're going to track that whether you're tracking that from an executive standpoint or a board or whoever you're tracking that to. And then number 7, we get this section a lot because typically practice groups or hospitals, really haven't had to do a lot of marketing in the past, and they really look at this as an opportunity to get new patients. We talk a lot about, supporting employers, whether you're a hospital or practice area, practice groups, and companies around where you're located are looking at ways to reduce their healthcare costs. A lot of companies have gone to self-insured, and so there's a lot of opportunity for groups to service current employers. We get a lot about schools. And how do you really get the word out to your current patients and new patients about your video telehealth program and really getting kind of that referral system out there? And then lastly, learn, schedule kind of an advisory board to provide feedback, improve the process, and then repeat it. And that really goes back to, this is really kind of a circle here. Because once you do that, you can go back to number 3. And once you've done practice areas, or by department or however you want to do it, and you've got some learnings, then you roll out additional areas from those learnings and continue to repeat that from that perspective. So I want to talk about a couple. I'm actually going to jump a couple slides here and come back. I want to talk about, if you're on this webinar and you currently don't have video, telemedicine, telehealth, whatever you want to call it, you don't have it in place today. This is a pretty important matrix on, as you're talking to companies, what you should be thinking. Your criteria is going to be a little bit different. But if you're a hospital or a practice group, whatever it may be, mental health facility, addiction center. But here's some things you really want to think about. There's several buckets of telehealth vendors out there. There's a lot of, maybe it's the kind of telephony hardware players that you might have on a cart, that, you're using originating site, and being able to connect to other facilities. Those are not going to be the same provider that's going to be able to allow you to see patients in home. It's got to be on a cart. It's got to use their equipment. You might have had to put in some servers. It's very expensive, and not scalable outside of the facility. And then you have the big players, the $250,000 to $1 million players that are going to take you 9 months to implement, bunch of EMR integrations, so forth. And if you're on this call and those aren't already implemented, you probably won't be ready by January or mid next year. And then you have the folks that provide SaaS technology, software as a service, that depending upon the complexity, some providers, you're going to use their company, their brand, you're going to send their patients to a different company. It's not going to be branded, and you could probably be live in weeks or months. And then there's folks that make it really easy to implement, that is branded for your hospital or your practice area. Everything kind of patient facing is under your kind of guidelines, and you can get that implemented very quickly. So you want to put your providers in those buckets and make sure you're comparing apples to apples and not apples to cantaloupe or watermelons in that scenario. So I want to talk about a few buckets of what you should be thinking about and considering when you're looking at a provider. Number 1, the patient experience. If it's too hard for the patients to connect and they have to do a bunch of downloads on their computer, you have to have connections back and forth, and it takes them, some providers, it could take 10 minutes for that connection to happen. You might get them to use it once if they have to, but you're not going to have kind of that repeat. You want that patient experience to be, number 1, fully branded by your hospital or your practice group, so the patient knows that, it's from you. You want to really begin with, the good thing about being a patient is everybody that's an executive or a doctor or whatever, is they're a patient as well. So it's just like being a consumer. You want it to be easy, you want it to be frictionless, and you want them to tell their friends about it so they use it too. You want to really think about the ROI. So a lot of companies will think just purely about the technology cost, and they'll think about, maybe it on a license fee, or, maybe it's an upfront fee, whatever it may be. You want to really think about it, and this goes over here from a hardware perspective. Video has come such a long way in the last 2 years, and it's changing on a daily basis. I really would have advised against installing any type of hardware, servers, things like that you have to hire additional staff and host it on your premises, things of that nature. By the time you get it implemented, it will be obsolete, and something new will be out. So you really want to think about the total cost of ownership when you're comparing vendors. Do you have to buy equipment? Do you have to buy equipment for every doctor? Do you have to buy web cameras? Do you have to buy specific computers or other technology? And then are you going to have to maintain that? Can you buy kind of any type of hardware you want? The web cameras have gotten so great, in laptops and computers. You can use, some companies you'll be able to use your existing hardware. Some companies you'll have to buy that company's specific cameras. And so you really want to put that into kind of your total cost of ownership from that perspective. Then time to implement. It seems like on a daily basis, I talk to hospitals that have been in implementation for, over a year. And because there's so much turnover with EMRs, you don't want to get really too tethered to one EMR over another, because IT likes to switch out EMRs, and businesses like to switch out EMRs. Most hospitals, because EMRs are very focused on practice areas, most companies don't want to tie their video telehealth to an EMR, because then if they go to change it at some point, sometimes you'd have to change that video telemedicine provider or have to reintegrate. So you really want to think about that integration. A lot of IT staff doesn't want to touch the EMR, or you already have that roadmap locked out. So you really want to think about that and really understand from your IT folks, if you're going to integrate, when do they have available resources, and what's that really going to cost? The next one is reporting. If we go back to kind of that test and learn and the ROI, you want to make sure that the reporting aligns with how you're going to be measuring it. So thinking about that, thinking about the journey, and then really getting feedback. So getting that patient feedback, getting that doctor feedback to really make that process better. The worst thing you can do with video telehealth is not have any feedback from the patient, and then 6 months later you understand you have all these bad reviews that you weren't able to do anything about. And then the last one is really operational openness. So a lot of people are really tied to, we do it this way, we've always done it this way, this is how we operate, and getting really tied into their current operation. I encourage you to really think about how video applies to your operations and how it can improve it. There's no better way to be open to what you're doing today, and incorporating video in that process. So don't be completely closed-minded of trying to button something into exactly what you do today. Try to improve it at the same time if you can. So I want to go back and talk a little bit. We fall into that bucket of a very effective but simple to roll out and simple to train your staff video telehealth platform. It's going to be a lot different than you've probably seen. And so I want to talk a little bit about that. First, we're the only company that puts a video telehealth or telemedicine video widget right on your own website. So if you see this hospital website here, you have the video right off it. It's completely branded for your own practice group, addiction center, hospital, whatever it may be. So if you're, as you can see, this hospital's colors have green in it, so it's matching there. Everything is customizable, what you want to call it, everything from that perspective. Anything that's patient facing is going to look as if it was your own technology. We stay behind the scenes. Your doctors, your PAs, your admission staff, whatever it may be, log into a portal. It's software as a service. It's a browser-based portal. As long as they have access to the internet and they have a webcam, it can be a built-in webcam. It can be a $30 plug-on webcam from Amazon, as long as there's access to Chrome or Firefox. A couple of things I want to point out. This can be added to any page on the website. It takes about 5 minutes to add it, 3 minutes if you're a good web person, 5 minutes if you're average. It's very quick, and you can be up and running. The cool thing about it is there's 2 ways to connect from the patient. Number one, each doctor, PA, or user has their own individual code. There's no exchanging personal information. There's no giving out cell phone numbers, anything like that. Doctors really like that. So whether you're scheduling an appointment at a specific time or it's after hours, a doctor can give out their individual code right from the website. The patient enters that code and the doctor gets notified in the portal that somebody's waiting on them. The second thing is we're the only company that has practice or reason-based routing. That can be a couple of things. So if you're a hospital and you have a pediatrics group and you want to start providing after-hours pediatrics to go to any pediatric doctor that's on call that night, I could go off your website, click pediatrics. There could be, 5, 10, 50 doctors in that particular group, and they would get notifications in the portal and be able to take that video call. You can skill your staff to the appropriate group. They can be in one group, many groups, whatever it may be. So here's how it works. Any of the pages within your site, or you could have a dedicated landing page, whichever you choose, the widget pops up here. They select it. The patient then videos right off of the site. There's no downloads that are needed. It pops up right on the site. It comes in this small window, and then the patient can make it large from that perspective. It's the highest quality HD 4K video, so you can literally see wounds, you can see in eyes, you can see skin, you can see very detailed information. Over here on the doctor side, there's a queue here that you can pick up the video from. You get notifications in your browser, and then this is what the doctor view looks like. So the patient's in this larger screen, doctor can see themselves on the small screen. Both have the ability to mute the video if they had to talk to somebody, all HIPAA compliant. The great thing is after this, both the doctor as well as the patient gets a quick survey, fully customizable, quick 3 questions. Really, this is around patient satisfaction. So from a HIPAA perspective, you're not asking them why they called or anything health related. You're asking them how their experience was today. You're asking them if they'd use it again. You're asking them if it prevented them from having to come to the office, whatever you may want to ask them, but you're really measuring that, and you're getting feedback on the process. You're getting feedback on the doctor. You're getting feedback on the service. On the doctor side, you can ask any 3 questions you want as well. This could be really, what was the outcome? Is there follow-up required? Do they need to come into the office? This could be notes from an administrative perspective for assistants or front staff, back staff to follow up on the next day. Here's a closer look at the dashboard that I was just showing you. So number 1, there's 2 queues in the technology. You have your personal one. So if I'm logged in as a doctor, I have a dedicated number up here. It stays the same. My staff can schedule appointments. However you schedule appointments today, no need to get a new scheduling system or modify that. Your staff can schedule those appointments and put in that code. Secondly, you have the group consults. From a group consults perspective, this is really about practice areas. This is about it coming in. So if myself and 2 other doctors covered pediatrics, we would all be able to see pediatric calls that come into this group. If the oldest call would be at the top, if I was available, all I'd have to do is accept it here. I would take that patient out of the queue. Now, I might be in another group as well. Maybe I'm in, OBGYN. And so I could get those calls as well from that perspective. You get to see all the reporting of the patient that connected to the doctor, what group they came in, how long was the video call, which helps from a billing perspective. And then there's all types of graphical reporting that you're able to see. And this really helps you with getting that ROI, with being able to really see what's going on, make those operational improvements from that perspective. As an administrator of the system, you'll be able to manage access for all your doctors and PAs, put them in the groups, see who's available, see who's in consultation, manage it all yourself. Very simplistic. To get doctors and staff up to speed, it takes about 15 minutes to train them. So it's very quick to roll out within days, not weeks, not months. So that's one SaaS technology that I can kind of show you that's a quick to implement from that perspective. So I know we only have a few minutes left. Went through a lot of information really quickly. On the right-hand side, you should have a chat functionality. If you have any questions, you can submit those. I'll be happy to answer any questions that you might have. If there's any questions that you might have post this webinar, my contact information is on this particular slide. There's a couple of infographics that you saw a lot of this reference today on stats about the patient experience, as well as a lot of the information on the billable codes. We will be pushing those out to you after this call. So your screen will pop with the ability, with a little notification if you'd like to download those. And then we will be emailing you the recording if you'd like the recording within a few days as well. So be sure to grab those. So a couple of questions. I will start going through some of the questions. So the first question is, if I have a doctor's office or a private practice, how much would it be to add this technology? So we do have smaller packages that start at $399 a month. Very cost effective, get an ROI usually within your first month. And that gets you up to 3 users. That typically will manage any kind of smaller practice, and then it goes up from there. So we're not talking, thousands or $100,000s of dollars, which is why it's easy to implement and cost effective from that perspective. What's the biggest barrier you're seeing from providers deciding to implement? The biggest barrier is really knowledge. So the biggest barrier of pretty much everybody that we talk to is really just taking somebody that's inside the organization, assigning them to video telehealth, and they just really don't know where to start. Or, there's so much information online and really just not getting all the information of how to get going. And so a lot of it's really just education on process, education on where to get started, and really just sitting down and coming up with that plan. And that's really why we put together, and you'll see in the one of the we also have a healthcare ebook, and if you download it, you'll see all these steps, but in a lot greater detail, which is why we kind of put that together, because that's where everybody's getting starting to really struggle. Well, I want to thank everybody for coming to the webinar today. I will put this back up if there's any questions that you think of post the webinar. Emily is going to push out the handouts, and you'll be able to get those infographics. If you have any further questions, or you want a more detailed webinar demonstration, I will be happy to show you the technology live. Those handouts have been pushed, and thank you guys for joining today.